about menstruation. Again, one of the most important chapter in gynecology. Now, I'm not telling in detail, but only picking up the important points which are necessary. The first one is the follicular phase. Okay, follicular phase, which starts from 1 to 14 days. 1 to 14 days. Remember, this is a proliferative phase. Proliferative phase. And what helps in the proliferation? Or when we say a follicular phase, right? So follicular development occurs. So which is the hormone necessary for the follicular development is, that is the FSH. Okay. Now, we have already said it's a proliferative phase. That means endometrial proliferation should occur. And for endometrial proliferation, we have estrogen. But remember, when the estrogen starts working, then the FSH suppression starts because of the negative feedback mechanism that is going to start. So the first one is follicular phase, in which it is a proliferative phase, and we have FSH which is acting, and that is why we have a follicular development. Now, next one is estrogen hormone, which is responsible for the endometrial proliferation, and then the FSH suppression. Okay, next one. In this particular phase, progesterone will be low. Progesterone will be low. You have to remember this. Okay, now coming to the ovulation. Ovulation is on the 14th day, or days of when the days of cycle, that is 14th day of the cycle. Okay, now estrogen induced LH surge occurs. So we have already said over here in this particular follicular phase that estrogen, what it does, it suppresses the FSH. So once FSH is suppressed, the follicular development stops and the LH surge starts. Now, when LH starts coming and acting on it, then we have ovulation that is taking place. Okay, and ovulation takes place after 32 to 36 hours after the LH surge. This is a very important thing which you need to remember. So, 32 to 36 hours after LH surge, ovulation will occur. And 10 to 12 hours of the LH surge, when it starts, the LH will be at its peak. So LH will be at its peak by 10 to 12 hours. Okay, so this is about ovulation. Now, with respect to this, we have a little more information. The size of the Graafian follicle before the ovulation is 18 to 20 mm. Remember, this is important. 18 to 20 mm. Now, and the corpus, next one is the ruptured Graafian follicle is known as the corpus luteum. So the ruptured Graafian follicle is known as the corpus luteum. Now, we already said over here about the LH surge, right? Now remember, and here we said estrogen-induced LH surge. So with regards to this, remember this point. LH surge is initiated by the estradiol, the component of the estrogen, and it should be more than 200 picogram for 48 hours. And now when that happens, the LH surge is initiated. So remember, when the estradiol is more than 200 picogram for 48 hours, the LH surge is initiated. Okay, so this is about LH surge. Now, with respect to that of ovulation, we have a pain during ovulation, and that is called a Mitchell-Merz pain or Mitchell-Merz syndrome. That is nothing but the pain during ovulation. So this is about the ovulation. Now, one more thing I want to say is estrogen is secreted from granulosa cell and the androgens are secreted from the theca cell. Now, we know that in a female, there is androgens being secreted as well as estrogen being secreted. But androgens are, converted to estrogen. And the enzyme that is responsible for the conversion of androgen to estrogen is aromatase. Remember, it is aromatase. So this was about the follicular phase and the ovulation. Follicular phase, that is 1 to 14 days. Ovulation on the 14th day. The hormones that is responsible for the follicular phase is estrogen. We have FSH. Now coming to ovulation, we do not have a FSH which is working, but we have a estrogen and we have a LH that is going to work. Okay, so coming to the next one, we have a luteal phase. In luteal phase, that is 15 to 28 days. The rest of the days, there is a luteal phase. So remember, luteal phase is a phase in which the secretory secretion occurs. Okay, it's called the secretory phase also. Now, the corpus luteum formation we have already seen over here. The ruptured Graafian follicle after the ovulation is known as a corpus luteum. Now, in case of luteal phase, the corpus luteum will secrete progesterone. Corpus luteum will secrete progesterone, and this will again lead to endometrial maturation. The proliferation of the endometrium, that is through estrogen. But endometrial maturation is due to progesterone. Okay, now, in this particular phase, both the LH and the FSH is decreased. They have decreased. The work of LH of causing the ovulation, that is over. So now LH and FSH both are decreased. Now, corpus luteum regresses at the end of this particular stage. By 28th day, that is 28th day, corpus luteum will start regressing. Because at that point of time, FSH again will start working, and there'll be a decreased progesterone and estrogen. Okay, so corpus luteum regresses at the end of this stage, and there will be decreased progesterone and estrogen in this particular phase. So once again, I'll tell you about all the phases. The first one is the follicular phase, in which that is the time period is 1 to 14 days. Okay, then proliferative in nature. FSH is responsible for the follicle development. Estrogen is responsible for the endometrial proliferation, and then the FSH suppression. Progesterone is low in this particular phase. Okay, now, next one, after the 1 to 14 days, 14th day, we have ovulation that is taking place, and that is because of the LH surge that was induced by estradiol. And after 32 to 36 hours of LH surge, ovulation will occur. Okay. Next one is the luteal phase, that is a secretory phase, and corpus luteum, which was already, after ovulation, we have a corpus luteum, and that will start secreting progesterone. And this progesterone will help will lead to the endometrial maturation. In this phase, decreased LH and FSH. Now, one more thing with regards to corpus luteum is it doesn't secrete only progesterone. So it secretes inhibin A and estrogen. So these are the hormones that corpus luteum secretes. You need to know this, very important one. So corpus luteum secretes progesterone, inhibin A, and estrogen. But corpus luteum is actually maintained by, in a non-pregnant state, it is LH, and in a pregnant state, it is a HCG. So these are the two things which you need to know about corpus luteum. So corpus luteum is maintained by LH in the non-pregnant state and HCG in the pregnant state. And corpus luteum secretes progesterone, inhibin A, and estrogen. Okay, so luteal phase, you need to remember it's secretory phase, corpus luteum, which secretes progesterone, and progesterone leads to endometrial maturation. And in this phase, LH and the FSH will be reduced. And at the end of this particular stage, because of the decreased progesterone and the estrogen, corpus luteum will start regressing. Now, again, a little information of corpus luteum. The lifespan of corpus luteum is 10 to 12 days in a non-pregnant state. Remember, non-pregnant state, it is 10 to 12 days. But in a pregnant state, it is 10 to 12 weeks. See the difference? In a non-pregnant state, it is 10 to 12 days. But in a pregnant state, it is 10 to 12 weeks. You can remember, it's easy. So the maximum corpus luteum activity is seen on the 8th day after ovulation and 22nd day of the menstrual cycle. We know that only by 28th day it is going to regress. So by 22nd day of the menstrual cycle, the corpus luteum activity will be in its maximum. So 22nd day of menstrual cycle means the 8th day after the ovulation. Okay, so this was about menstruation. Next one, coming to the endometrial regeneration. Now remember, the endometrial regeneration during the next cycle is from the stratum basalis of the endometrium, or stratum basalis layer of the endometrium. From there, the endometrium will start regenerating. Now, the first sign of endometrial biopsy, that is a clinical aspect with regards to menstruation, that is the first sign of endometrial biopsy is the basal vascularization of endometrium. So vacuolization of the endometrium. There will be, in this particular basal layer, there will be vacuole formation. Okay, of the endometrium. That is a endometrial biopsy, the first sign. Next one, immediately after menstruation, the thickness of the endometrium is 0.5 mm. Remember 0.5 mm, that is the thickness of endometrium immediately after menstruation. This is been asked in the previous questions. The next one, vaginal changes during menstrual cycle. So before knowing the vaginal changes in the menstrual cycle, you need to know the three kind of epithelial cells in the vagina. The first one is the basal or the parabasal, second one intermediary, and the last one is superficial. So it will go superficial layer, we have an intermediary layer, and finally the basal layer. This is from outwards to inwards. Okay, so a proliferative change when the estrogen is dominant at that point of time, it is going to act on the superficial cells. Okay, the proliferation will occur in the superficial cells. Now, in the secretory stage, progesterone is dominant, and that is from the intermediary cells. Okay, so the progesterone will act on the intermediary cell during the secretory phase, and estrogen will act on the superficial cells in the proliferative stage. This is very again important one to remember. Next one, increased order of potency of estrogen. We spoke about estrogen being acting in the may it be luteal phase or may it be in a follicular phase or any phases. Now we need to know what is the order of potency of the estrogen. Now these are the three derivatives of estrogen we know. Now remember, estriol is a highly potent estrogen. After estriol, next one should be estrone, and lastly we have estradiol. So if at all, it has been all these three and one more has been asked in your examination, and it has been asked whether or which one is the most potent estrogen. Your answer should be estriol. Your answer should be estriol. Do not forget. First one estriol, next one estrone, and the third one is estradiol. Okay, so E3, E1, and E2. So next one is menstrual bleeding. Now we saw a little of menstrual cycle, next one menstrual bleeding. Now for this we need to know a normal or a regular. Regular one, how many days of cycle it is or how much should be the bleeding. So now we say 21 to 35 days is the cycle, which is normal. Okay, after 35 days we have different terminologies for that, or before 21 days or less than 21 days we have a different terminology that we'll deal later. So between 21 to 25 days is a normal cycle with an average of 28. Remember, with an average of 28 days. Now, next one, the bleeding is for 2 to 8 days, is again a normal. So here in this point, we are dealing only with a normal one. And the average amount of blood is 50 ml. The average amount is 50 ml. Okay. So this is about the normal one. Now coming to a little abnormality. So regular, but if the cycles are regular, but if the days are less than 21, so but less than 21 days length, at that point of time we call it to be a polymenorrhea or a epimenorrhea. Remember the terminologies, polymenorrhea and epimenorrhea, where the cycle is less than 21 days. Now 21 to 35 already I have said the range. Now if at all the cycle is more than 35 days, it is oligomenorrhea. Oligomenorrhea, very important feature in case of PCOS. Next one, if at all menstruation occurs more than 8 days in a duration or more than 80 ml, that is called menorrhagia. Remember menorrhagia, 8 days in duration and more than 80 ml, that is menorrhagia. But if at all it occurs less than 2 days or less than 20 ml, that is called hypomenorrhea. Okay. So once again I'll tell, more than 8 days, more than 8 days in duration or more than 80 ml, that is called menorrhagia. And next one is less than 2 days or less than 20 ml, that is hypomenorrhea. Now next one, irregular acyclic bleeding from the uterus, that is called as metrorrhagia. It's just irregular. See, all this, they were, it was, then some regularity was there. But here we have an irregular acyclic bleeding from the uterus, that is metrorrhagia. Okay. So next one is little of DUB. So abnormal uterine bleeding without any clinical, remember, without any clinical detectable organic systemic or iatrogenic cause, that is DOB. And under DOB, this point is very important to remember. So we have ovular, we have anovular. Now here, a cystic glandular hyperplasia. This is the most important thing which you need to know in DOB. Cystic glandular hyperplasia, which is otherwise known as a Metropathia hemorrhagica. Remember, Metropathia hemorrhagica and a Schroeder's disease. So cystic glandular hyperplasia, otherwise termed to be Metropathia hemorrhagica and Schroeder's disease. That is an abnormal bleeding in the premenopausal woman. That is happening in the premenopausal woman. And that is due to the disturbance of the rhythmic secretion of gonadotropins. Now, in this, what will happen? Estrogen secretion will occur without any negative feedback mechanism to inhibit the FSH. So, with respect to this, I would like to say the hypothalamo-pituitary ovarian axis. So, we have a hypothalamus, then we have a pituitary gland, and then we have an ovary. Finally, we have an endometrium. Now, remember, from hypothalamus, gonadotropin releasing hormones are being secreted, right? Now, this gonadotropin releasing hormone will go and act on the pituitary gland. And thus, we have two hormones, that is FSH and we have LH. Now, FSH will go and act on the ovaries, leading to follicular development. And now, during this phase, same time, because of the FSH that is going to act, the granulosa cell, I'll write over here, the granulosa cell of ovaries will start secreting estrogen. So estrogen will do two things. It will go and act on the endometrium, thus proliferating the endometrium, and the LH. It will also go and act, estrogen also will start the LH surge. Okay. So these are the things which is going to happen. Now, in case of a cystic glandular hyperplasia, what will happen is the gonadotropin releasing hormones are not secreting enough amount of FSH and LH. Okay, this is after menopause, remember. So, now what will happen is estrogen will anyhow be secreted in little amount, but there is no negative feedback mechanism to stop the FSH. And that is why an endometrial proliferation will continuously occur. And because of that, there will be shredding of endometrium. Okay, endometrial shredding will occur. So, because of that, remember the uterine wall, when we do a cross section of it, we can see a 25 mm. That is very huge. 25 mm in cross section, the thickness of it. So, this is about the cystic glandular hyperplasia and the Metropathia hemorrhagica, otherwise known as, and the one more name which is called as a Schroeder's disease. So, this is about a DUB. Next one, coming to the puberty. We'll finish this fast. So puberty, you need to remember, before going to the other features of puberty, a little about the hormones that is acting on the puberty. Gonadotropin releasing hormones, which is secreting FSH, LH, and then we have estradiol. Okay, apart from that, we have TSH, we have androstenedione, as well as a leptin. Okay, leptin, which is found in the adipose tissue. Remember, these are the things which is necessary for the puberty. Now, talking about the sequence of puberty, which is very important. Okay, an accelerated growth. The first one is an accelerated growth that is going to happen. Okay, next one that is going to happen is the thelarche. Now, what is thelarche? Thelarche is the, breast changes. Okay, breast changes is thelarche. Next one is adenarche. The other name for adenarche is puberche. Both puberche or adenarche. Puberche or adenarche is nothing but the secondary sexual hair growth. Secondary sexual hair growth. Then we have a growth spurt. That means suddenly the person or the girl will start feeling more of appetite. Okay, all those features are growth spurt. And finally, we have a so fifth one, we have a menarche. So this is a particular sequence which is not to be forgotten. Accelerated growth, that is because of the growth hormone. Then we have a thelarche, we have adenarche or puberche, and growth spurt, and finally we have a menarche. Now, staging of puberty, remember, if at all it is done, which staging is being used to stage a puberty. That is called the Tanner staging. It is called Tanner staging. Now, we know adenarche and puberty, that is pubic and axillary hair growth. Remember, this depends upon the adrenal androgens. And which adrenal androgen we are talking about? We are talking about the androstenedione. So, androstenedione is the hormone we are talking about here. Okay. So, next one is breast development. Breast development is due to estrogen. Okay. Now, one more thing you need to know is the staging of hirsutism. Now, before that, we need to know what is hirsutism. Hirsutism is nothing but the sexual hair growth. Sexual hair growth. But where? On the face, mainly in the midline of the body. Midline of the body. May it be face. We have next is chest. Okay. So, male pattern of hair growth is known as a hirsutism, and that is because of androgen. Androgen that is acting. Or unopposed androgen. That would be a little apt way to say. So, unopposed androgen. Next one. The staging of puberty, we know that is Tanner staging. So, staging of hirsutism is done by Ferryman-Galway staging. You have to remember this. Ferryman-Galway staging. The name is very important to know. Okay. So, once again, sequence of puberty such as axillary growth, thylarche, adenarche, puberche, growth spurt, and menarche. So, coming to the staging of puberty, we have Tanner staging. Then pubic and axillary hair growth depends on the adrenal androgens. And breast development is due to estrogen, and staging of hirsutism is by the Ferryman-Galway staging. Remember this. So next one, delayed puberty, a little of abnormalities. Now when we say puberty is delayed, when there is an absence of breast development, as well as menstruation by the 13 years. By 13 years. Okay. Now, if you're talking about only the absence of menstruation, that should be by 15 years. Both together, 13. But solely only menstruation is absent, irrespective of the breast development, that is 15 years. The most common cause of delayed puberty is the constitutional cause. Now, when we talk about constitutional cause, it even can be a familial history. Remember, it can be a familial history. It can be any other physiological delay. Okay. Next one is a precocious puberty. Talking about precocious puberty, the thylarche should be by or before 8 years or before, menarche by 10 years or before. This is the criteria. The breast development before 8 years and menarche before 10 years. And if at all it happens, we call it to be a precocious puberty. So in relation to precocious puberty, you need to learn or you need to know about this syndrome. That is McCune-Albright syndrome. So if at all there is some precocious puberty, we can even suspect a McCune-Albright syndrome. And that will be having, or that is characterized by a sexual precocity. Then we have multiple cystic bone lesions, endocrinopathies, and then a caffeoli spots on the skin. So this is the representation of McCune-Albright syndrome. So remember, a person with McCune-Albright syndrome can have a precocious puberty. Okay. So next one is about dysmenorrhea. Talking about dysmenorrhea, we know there are two kinds of dysmenorrhea. One is a primary and one is a secondary. Primary is termed to be a spasmodic, and secondary we term it to be a congestive. Now coming to the spasmodic, remember we do not have any pelvic pathology in case of a primary or a spasmodic dysmenorrhea. And it is confined to the ovulatory cycles. Confined to the ovulatory cycle. Okay. Now, it might be caused due to uterine myometrial hyperactivity. So remember, a spasmodic dysmenorrhea can be caused due to uterine myometrial hyperactivity. Next one is imbalance in the autonomic nervous control of the uterine muscles. So what will happen is when there is a imbalance in the ANS control of the uterine muscles, there will be overactivity of the sympathetic nerves. That will lead to the hypertonicity of the circular muscles of the isthmus and internos. That is why there will be contractions that is occurring. And because of that, there can be a pain. So this is a pathophysiology, remember. What will happen is imbalance in the autonomic nervous system, nervous control over the uterine muscles. That will lead to overactivity of the sympathetic nerve. And because of that, there will be hypertonicity of the circular fibers of the isthmus and the internos. And then There'll be also increased action of the prostaglandin. Remember prostaglandin? Why there is an action of the prostaglandin? That is because of the progesterone and the vasopressin that is acting. And when the progesterone starts, the prostaglandin starts acting, we have a myometrial contraction. Remember, we have a myometrial contraction. The next one is congestive or a secondary dysmenorrhea. Remember, in case of primary dysmenorrhea, we mentioned that there is no pathology. There is no pathology, right? Now, but in case of a secondary dysmenorrhea, it comes along with the pelvic pathology. It comes along with pelvic pathology. And this occurs because of the increasing tension in the pelvic tissues due to a premenstrual pelvic congestion or an increased vascularity in the pelvic organs. Remember, premenstrual pelvic congestion and increased vascularity in the pelvic organs. Okay, if any lesion is there in the pelvic organ, now that particular lesion also is supposed to be supply. I mean that we have to supply blood to that particular lesion also. So basically, there will be increased vascularity because of that particular thing. For example, fibroid. Fibroid, we know it is nothing but a growth that is happening, right? So for that growth, we have to supply blood. So the blood which is being supplied to the normal uterus is not enough. It should be increased. So basically, in this particular condition where there is a pelvic pathology, increased vascularity in the pelvic organ occurs. And not only that, there will be a premenstrual pelvic congestion. And the tension or the pain is occurring because of this particular theory. Now, how will be the pain? The pain will be a dull pain which is situated in the back and in the front. So there will be a back pain as well as there will be an abdominal pain. So dull pain situated in the back and in the front, and the pain will be always better by bleeding. Remember, always better by bleeding. Okay. So next is unilateral dysmenorrhea. Remember unilateral dysmenorrhea. Now that is something called the ovarian dysmenorrhea. Okay. So ovarian dysmenorrhea means, now how, or what is an ovarian dysmenorrhea? With regards to that, you need to remember is a right ovarian vein syndrome or a pain syndrome. So here you can see a right ovarian pain syndrome. Remember, during right ovarian vein crosses the ureter at the right angle. So whenever there is a pelvic congestion, remember, whenever there is a pelvic congestion that is occurring and the increased blood flow, there might be marked engorgement of the right ovarian vein. There will be marked engorgement. Already with the pathology we have mentioned over here. Because of that, there will be a marked engorgement in the right ovarian vein. And when there is a marked engorgement, the pressure will fall on the ureter because the right ovarian vein crosses the ureter over here. Okay, so pressure is on the ureter. And when there is a pressure on the ureter, there will be stasis of urine. There will be a blockage. And because of that, there will be stasis of the urine. And that will lead to infection. It will lead to pyelonephritis. And finally, we have pain. Okay, so that is called a ovarian dysmenorrhea. It usually occurs in bicornate uterus. Okay, and unilateral location of pelvic endometriosis. Okay, so this is a unilateral location of the pelvic endometriosis. So this is about the primary dysmenorrhea, secondary or the congestive dysmenorrhea, and the unilateral dysmenorrhea. Coming to the next one is about the premenstrual dysphoric disorder. This is asked once actually. So premenstrual dysphoric disorder. In this condition, there will be a somatic and psychological symptoms that occur in the second half of the menstrual cycle. So in the second half of the menstrual cycle, there might be some kind of physical as well as a little psychological symptoms that is appearing. So the somatic symptoms are bloating, pain in the breast, skin disorders, pelvic pain, nausea and vomiting, edema, and a little of cravings. The lady will get it. Now coming to the psychological symptoms, symptoms like irritability, aggression, tension, anxiety, sadness, mood lability as well as depression. So these are nothing but the mood changes and the physical changes that occur during the second half of the menstrual cycle. Okay, that is termed as premenstrual dysphoric disorder. Okay. So the next one is menopause. So after menstruation, we have the menopause. So no menses for more than 1 year with a mean age of 51 years. So mean age of 51 years and more than 1 year if the lady doesn't attain her menstruation, we call it to be a menopause. And diagnosis is based on the history and increased FSH level. Okay, increased FSH level. I'm not going into the details of menopause, like what are the symptoms of osteoporosis or any other symptoms. I'm not talking about it. But here, the one point which you need to remember is no menstrual cycle for more than 1 year and with a mean age of 51 years. And what is the diagnosis? Diagnosis by increased FSH. Okay. Next one is about amenorrhea. Now, talking about amenorrhea, we have a primary amenorrhea, we have a secondary amenorrhea. Now, I'm not going to deal with the physiological primary amenorrhea or neither with the physiological secondary amenorrhea. So, in short, physiological primary amenorrhea means before puberty or after menopause or even during lactation. Secondary is again during time of pregnancy. Okay, so this was about the primary amenorrhea, that is physiological one. Talking about the pathological primary amenorrhea, the most common cause of pathological primary amenorrhea is gonadal dysgenesis and Turner syndrome. Gonadal dysgenesis and Turner syndrome. Now, when we classify primary amenorrhea, we know we have hypogonadotrophic hypogonadism, hypergonadotrophic hypogonadism. Then we have the congenital malformations. Then we have chromosomal abnormality, thyroid dysfunctions, and so on. But among all this, when we jot down which is the most common cause of primary amenorrhea, you have to write as the gonadal dysgenesis and the Turner syndrome. Okay. The second common cause is the Mullerian agenesis. So the first one is chromosomal, and the second one is abnormality with the anatomy. Okay. So Mullerian agenesis, and the next one, first one was gonadal dysgenesis and Turner syndrome. The second one was Mullerian agenesis. And what is the best investigation method for primary amenorrhea? And that is karyotyping. So in our textbooks, we already know there is a big chart which is given for the investigations of primary amenorrhea. See whether the weight of the girl is short or whether the weight of the girl is she's tall or anything. Then USG. But what is the final one? The final one, everything is the end one or the end investigation which the physician sends the girl is for a karyotyping, which will determine. Okay. Now coming to the Cryptomenorrhea. Cryptomenorrhea is again one of the cause of primary amenorrhea, and that too pathological primary amenorrhea. Now, talking about cryptomenorrhea is also known as a hidden menstruation. Okay, hidden menstrual flow. Now, while talking about the vaginal septum, that is the transverse vaginal septum, I already spoke about the imperforate hymen. So when there's an imperforate hymen, we know that the menstrual flow or menstrual blood will not be coming out. So that will come under cryptomenorrhea. So imperforate hymen is the most common cause of cryptomenorrhea. Now, if at all there is a hymen, how do we treat it? Or what is the management? We give a cruciate incision. Cruciate incision, when we give, we will be getting 4 flaps. And then we cut off the flaps. Thus, we will get thus the free flow of the blood occurs. Okay, that is a tardy flow will occur of the menstrual blood. The next one is a cervical stenosis again. Now this one was a imperforate hymen. We know even transverse vaginal septum can cause cryptomenorrhea because again the flow of the blood will not be there. Now if at all there is a cervical atresia itself, cervix, there is no opening in the cervix. So cervical stenosis or cervical atresia, or there is a blockage in the cervix. Okay, narrowing of the cervix. So cervical stenosis. In that particular case also blood will be collected beyond that. Now, second one, vaginal atresia again. Okay, vaginal atresia. Again a blockage. The same way, a transverse vaginal septum too. Now, transverse vaginal septum, when we talk about, it is a vertical fusion defect. That means the upper two-third of vagina from Mullerian duct and the lower one-third of the vagina doesn't fuse. That means the urogenital sinus doesn't fuse. So we have a septum over here. And what do we do with the septum? We cut the septum or the septal resection. Septal resection. That is a treatment method for transverse vaginal septum. So the next one is Turner syndrome, a very important one. So 45x0. You know it is a 45x0. And this is a perfect example for a hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism. Remember this. Okay. Now why hypogonadism when we talk about? That means talking about hypergonadism first. Hypogonadotropic means GnRH is acting normal. But there is a streaks of ovaries or streaks of gonads. Okay. The gonads are not being formed properly. Now there is no bar body in case of a Turner syndrome. And the other features are short stature with broad web neck, shield-like chest with a wide spaced or widely spaced nipple. Cubitus valgus, then we have a short metacarpal, or that the fourth metacarpal is short. Okay, we have mandibular hypoplasia that is known as a micronathia, and on USG it will reveal that there is a streaky gonad that could due to hypogonadism. Okay, now coming to the most common cardiac abnormality in case of Turner syndrome is coarctation of aorta. This is the point which is very important. Coarctation of aorta is the most common cardiac abnormality which is seen in Turner syndrome. Okay, so if a question comes, which among the following doesn't have a bar body? And in that, if Turner syndrome is there, you know what is the answer? And the answer is Turner syndrome. Next, coming to testicular feminization syndrome. Hey, you will find all this information in the intersex chapter. So testicular feminization syndrome is nothing but a male producing androgen, but the person is resistant to them. The male is definitely producing the androgens, but the person is resistant to them. Therefore, external genitalia will be feminine in nature. Okay, so external genitalia is feminine. So we will the person will be already having a testis, and all the other features will be there, but the external genitalia will be that of the females. Also, the breast development will be there, and that is because of the aromatization that is taking place. That is aromatization of androgen to estrogen. Even if the person is male, but because of the androgen which is being converted to estrogen, we'll be having all these features. Plus, there will be no axillary and pubic hair. And why do not they have an axillary or pubic hair? Because axillary and pubic hair is due to the androgen. And in this condition, that is testicular feminization syndrome, androgens are non-functional. So with regards to that, one more thing which I would like to say is the another name for testicular feminization syndrome is androgen insensitivity syndrome. Androgen insensitivity syndrome. Very important thing. Now, next one is talking about the Mullerian agenesis. So there will be breast development and the ovaries are normal, but they will not be a uterus. So if there is no uterus, there is no endometrial proliferation, and thus we do not have a menstruation. So we have amenorrhea. So on USG, we'll see there is no cervix or no uterus, no cervix, and fallopian tubes, as well as the upper two-third of vagina. So these are the things which are being derived from the Mullerian duct, right? So Mullerian agenesis, if it occurs, there is no uterus, no cervix, no fallopian tube, as well as the upper two-third of the vagina is not there. But here, the ovaries are present and the lower one-third of the vagina is present. So this is about Mullerian agenesis. Now, Kallmann syndrome. Kallmann syndrome and prolactinemia. Talking about Kallmann syndrome, we know that one of the features of Kallmann syndrome is anosmia. Together with anosmia, we have amenorrhea. Okay, now this is Kallmann syndrome occurs due to a failure of the migration of gonadotropin releasing cells. And from where does it release? It releases from the olfactory. It releases from the olfactory placard, the hypothalamus, and then we produce a gonadotropin releasing hormone. As there is a failure of migration of the gonadotropin releasing cells, we do not have a gonadotropin releasing hormone at all. And already we know when there is no gonadotropin releasing hormone, nothing is going to act on the pituitary. And when it is not been acting, we do not have a FSH and we do not have a LH. So we do not have a follicular development. And no, no inhibition of LH, and thus all the other the particular axis, that the hypothalamus pituitary axis has been blocked. And so that's why we have an amenorrhea. So coming to the next one is prolactinemia. Prolactinemia will be having amenorrhea, will be having galactorrhea, and along with that, a headache. So now hyperprolactinemia, if at all it is there, there'll be a negative feedback mechanism to the hypothalamus. Remember, hypothalamus, a negative feedback mechanism. Now, the same thing. When there is a negative feedback mechanism, it will not secrete a gonadotropin-releasing hormone. So no gonadotropin-releasing hormone, again, no FSH and LH. So this is what happens, and again, because of that, no amenorrhea. So the most common cause is prolactinoma. Remember, prolactinoma is the most common cause of prolactinemia. Okay, and how do we investigate it? We have to do a MRI of the brain. So we have Kaplan syndrome as well as prolactinemia. The end product is no gonadotropin-releasing hormone, and thus no LH, no FSH, and finally we have amenorrhea. The next one in detail about the secondary amenorrhea. If you are writing it down, please make 4 columns, which is very easy to do. So the first organ is the uterus. In uterus, if at all, there is an Asherman syndrome. Yesterday, I was talking a lot about uterine synechiae. Many times I told about uterine synechiae. The other name for uterine synechiae is, or synche is, Asherman syndrome. Okay, Asherman syndrome. Okay. So the uterus, we have a particular diagnosis, that is Asherman syndrome. Now, what you need to know is, in case of Asherman syndrome, there will be adhesions. Remember, adhesions will be there in Asherman syndrome. Okay, adhesions in the uterine cavity. Okay, now, when we do a hysterosalpingography, remember hysterosalpingography, we can see a honeycomb appearance. This is a major thing which you need to remember. In case of Asherman syndrome, you'll be having a honeycomb appearance. Okay, sorry, yeah, honeycomb appearance in case of Asherman syndrome. Now, when doing a investigation, remember the FSH will be normal, estrogen also will be normal. Progesterone challenge test is negative, estrogen progesterone challenge test is negative. Remember this. And there'll be history of abortion, history of curettage, and history of PPH. Actually, what happens is, because after a abortion or after a DNC or after your pubertal curettage, because of that, a sensitivity will occur in the uterine endometrium, and that is how the adhesions occur. Okay, so that was about an Asherman syndrome. I'm going to the ovaries. Talking about ovaries, the main diagnosis that can lead to secondary amenorrhea is PCOS. PCOS is nothing but polycystic ovarian syndrome. The other name for PCOS is Steen-Leventhal syndrome. Okay, these were the 2 people who said that anovulation, hyperandrogenism, as well as polycystic ovaries. These are 3 diagnostic criteria for PCOS. They were the one who said that. So now, in case of PCOS, I'm not going into the pathology in detail, but FSH will be normal to low. Now, with respect to that, remember, usually, there's a normal which I'm talking about. Normally, FSH is to LH ratio in a normal person should be 2:1. But in case of PCOS, FSH is to LH ratio will be 1:2. Remember, this will be the ratio. So, FSH will be normal to low, but LH will be increased here. Okay, estrogen is normal, progesterone challenge test is positive. Okay, and what are the features? I've already mentioned: hypoandrogenism, obesity, and anovulation. Anovulation, or also we can talk also oligomenorrhea. Also oligomenorrhea. That is cycles more than 35 days. Okay, so hyperandrogenism, obesity, and anovulation. These are the things. Next one is again ovaries. We have another diagnostic feature, that is a premature ovarian failure, otherwise a premature ovarian insufficiency. So in this, what happens is, before the age of 40 or by the age of 40, all the follicles get used up. Okay, now when there is a follicles getting used up, you do not have the FSH will not have something to act on. So FSH will be increased in this particular case. So remember, FSH is not getting used. So whatever FSH which is being released by the pituitary gland, it will be unused, and we'll be having a increased FSH, which is more than 40 international units. Remember this. Estrogen is decreased in this case. And then we have progesterone challenge test, which is negative. Okay, next one, the features of premature ovarian failure are osteoporosis. The important ones are osteoporosis and hot flushes. These are a little about premature ovarian failure. Okay. Next one is pituitary gland. In case of pituitary gland, talking about is FSH, LH, and estrogen will be decreased. Okay. And then hypogonadotropic hypogonadism. This is the feature. Okay. Now talking about that, we have one is Sheehan syndrome. In case of Sheehan syndrome, there will be a postpartum necrosis of the anterior pituitary gland. Okay, anterior part of the pituitary gland, there will be a postpartum necrosis that is taking place. Okay, now talking about that, the FSH, LH, and the estrogen will be decreased, and the progesterone challenge test will be negative in case of a Sheehan syndrome. Okay, so that was about Sheehan syndrome. Okay, so next one, Sheehan syndrome. What are the features? The features are lactation failure. We have when we do an MRI, we see an empty sella turcica. Sella turcica is a bony structure at the base of the brain that surrounds and protects the pituitary gland. Okay. No, apart from that, we'll be having headache and galactorrhea. Okay. So galactorrhea is of prolactinoma. So next feature of pituitary gland is prolactinoma. That in that prolactin level will be very high. Okay. And the features are galactorrhea and visual disturbances. So Sheehan syndrome, the clinical features are till here. There is lactation failure and headache. Now in prolactinoma, the prolactins will be very high and galactorrhea and the visual features. Apart from that, FSH, LH and estrogen again will be decreased in case of prolactinoma. Okay. And this can be counted under hypogonadotropic hypogonadism. Now coming to the next one is fibroid uterus. Now before going to a little details about fibroid uterus, we will just brush up with the types. Now, talking about the types of fibroid uterus, we know there are 4 types, right? Intramural, interstitial. You can see over here. Okay, inside the muscular layer, right? So this is intramural. Now, with regards to the intramural, this is the most commonest one. Most commonest one is intramural. If at all this intramural one, you know, grows grows towards the uterine cavity. See, this is going towards the uterine cavity. So this is known as a submucosal fibroid. Okay. So if at all the intramural fibroid grows towards the uterine cavity, we call it to be a submucosal fibroid. But if it is going outside, you can see intramural fibroid was here, it is growing outside. So this particular fibroid which grows outside is known as a subserosal. So subserous fibroid. Okay. The next one is a pedunculated, either into the cavity or you can see outside, which will be having a peduncle. This peduncle. Okay. So these are the types of fibroid uterus. Now coming to the little details of the fibroid uterus are, most common pelvic tumor is fibroid uterus. Most common pelvic tumor. These are the one-liners which you need to remember. The most common symptom of fibroid uterus is menorrhagia. And which one will be having menorrhagia? That is submucous. Okay. Now talking about the most commonest uterine fibroid is intramural, otherwise known as a interstitial. We already saw it over here. Intramural and interstitial is 75%. After that, submucous is important, or submucous is the commonest one. Then the subserous and finally a pedunculated. So according to the most common one, I'll write. First one is intramural or interstitial. Second one is submucous. Third one is subserous. And fourthly, lastly, we have pedunculated. Okay, now coming to the most common symptom of fibroid is menorrhagia, and that occurs in the submucous fibroid. Then we have a most common uterine fibroid is intramural or interstitial. Next one, fibroid with maximum symptoms. Again, it is submucosal fibroid. Okay. The most common fibroid that undergoes malignant change. Again, that is a submucosal. The one with maximum kind of symptoms will be the one which can undergo malignant change. Okay. The fibroids that lead to maximum abortion. Once again, that is submucosal. Okay. Torsions. Torsions are common in case of a pedunculated subserous fibers or fibroids. Okay. Pedunculated. We know that over here we can see a peduncle. Now, when there is a small, muscular tube-like structure and there is a growth in the end of it, so definitely there will be a twisting of the peduncles, and so peduncles torsions can occur in pedunculated fibers. Okay. Now, there is something called parasitic fibroid, and that are otherwise termed as a wandering fibroids, and that can be a subserous fibroid when it detaches from the cavity. So this was about the fibroid uterus, a little one. Other one, the urinary retention occurs in which kind of fibroid? Remember, urinary retention occurs in the posterior cervical fibroid. If at all fibroid is placed in the fundus, so if it is not of a big size, it will not give a pressure on the urinary bladder. But if at all a posterior cervical fibroid is there, then there will be urinary retention. Okay, now urinary frequency, it is in the anterior cervical fibroid. Next one is inversion is seen in, uterine inversion is seen in the fundal fibroids. Okay, when that means I'll show you over here. Okay, I'll show. We have a fibroid over here, which is increasing in size. That means what happens? There will be a dip over here. So ultimately, the uterus will be, the inversion of the uterus will occur. The uterus will become like this. Okay, it's just a way I showed. Okay, next one, the commonest, most common degeneration that occurs. We know there is a hyaline degeneration. We know there is a calcification, red degeneration, and all that. Okay, but the most commonest degeneration of the fibroid is a hyaline degeneration. Remember, it is a hyaline degeneration. But what is the most common fibroid to undergo calcareous degeneration? Remember, that is subserous. Any kind of fibroid may be, the commonest degeneration that is going to take place is hyaline degeneration. But which fibroid will undergo calcareous degeneration? That is subserous degeneration. Plus, if at all, there is a broad ligament fibroid, polycythemia is one of the feature. So remember, polycythemia is one of the feature of broad ligament fibroid. So this was all about fibroid. Remember, intramural fibroid or interstitial fibroid. Then we have a subserous, then we have a submucous, as well as the pedunculated one.